You do? So I'll talk about measuring brain function. I introduce myself via my conflict of interest. I have an affiliation to the University of Zurich. I'm co-founder and co-owner of two startup companies, MachineMD and Abegg, both of which are relevant for this talk. So be careful. I might have a financial interest in what I say. But the most part of my time I spend in ophthalmic practice. I'm an ophthalmologist and I see patients there. My subspecialty is the field of neuro-ophthalmology. And neuro-ophthalmology is about visual processing that does not happen in the eye, but more so in the brain. You may know that the image of the world is projected onto the retina. There it's transferred into an electrochemical signal. And from there, from the retina in the eye, it's transferred into the brain all the way back to the visual cortex. From there, the visual information is then redistributed through the cortex again, going down to the brainstem, and there guiding eye movements so that you get to see the things that are interesting for you in life. We separate these two systems into the afferent system and the efferent system. And what you can see, I think, on these slides is that the pathways that process visual information in the brain, they go across the entire brain all the way up and down to the brainstem. So it's not a surprise whenever something breaks in the brain, that can cause a loss of function. And this function can be seen at the level of the eyes because eye movements may be affected or pupil movements may be affected. So that's how I spend my day, looking at eye movements and pupil movements. That is not really an obscure science, but it is quite a long established clinical subdiscipline called neuro-ophthalmology. You can buy large books, volumes that have a long tradition of knowing how to find interesting diseases at the level of the eyes. And it's not about particularly rare diseases either. So, for example, one disease you may all know is multiple sclerosis. Roughly half of the patients manifest the disease at the level of the eyes, which may be an eye movement problem or which may be an optic nerve problem. So it is us neuro-ophthalmologists that are very often the first ones to see patients with multiple sclerosis or to establish the diagnosis. It's about the same for brain tumors, roughly half or 1/3, depending on what you count, of the brain tumors manifest at the level of the eyes. So maybe you see double or you don't see very well on one eye, and that may be the first symptom of a brain tumor. And so how is it being done today? It is a very archaic exam we really do. We use an occluder and a fixation object and a flashlight and maybe a prism bar, and we shine light into the eyes, look at the reaction of the pupil, or we move something in front of the patient and see how well the eyes move, or we use the prisms to measure the deviation of a strabismus in case one eye looks in a different direction than the other eye. This examination, me personally, took me quite some time to learn this, and I'm apparently not the only one. So there is a lack of that skill worldwide, and particularly in the US. So if you have an neuro-ophthalmic problem, as you saw, these can be serious. you have to wait 200 days up until you see a real specialist in this field, because there are not so many who are able to do this. Once you are at the neuro ophthalmologist's office, the doctors or their associated medical technical assistants will spend a lot of time doing these examinations. One estimate is it takes about 45 minutes to examine all these cables I showed you initially. So there is a lack of access to neuro-ophthalmology, and it's time-consuming and it's difficult. So no wonder people very often get it wrong. So you have a problem in your neuro-ophthalmic network. There is a roughly 50% chance that the first doctor will get it wrong and the wrong measures are being taken. So that's my reality. And that was the motivation to create something which does this very same examination, but rather than looking with our naked eye and showing visual stimuli by hand, we tried to integrate all of this in a VR headset, which is equipped with eye trackers. So there are two high-speed cameras that film the eyes that determine where at the given moment the eye looks and how big is the pupil, and you can use this to show stimuli. So what we do is very simple. We just do what we before did manually. We integrated this into an automatic program. And this can be done by basically anybody, so it's accessible more easily, it's automatic, and it's quantitative. All the stuff we measure manually are rather qualitative. So that might sound a bit strange to you, so I brought you an example of a patient I saw a few weeks ago. He had a stroke in the midbrain, the neurologist told me, and he seems to have some eye movement problem. So you can have a look at his eyes. That's actually during the recording. And can you tell me the diagnosis right away? Well, maybe you can't. So you need to analyze these eye movements if you can see them at all. And that's what our device does. It analyzes eye movements, and it's these graphs, they may not take 15 years to learn to read them, but they may take you a couple of hours up until you understand. So I try to explain. What this apparatus measures is that this particular patient, he has a misalignment of the eyes. So the right eye looks higher up than the left eye. That's his main complaint, by the way. He has a double vision. And this misalignment is about the same in all directions of gaze. So that's one thing we can see in this patient. When we have the patient look from left to right, or from right to left, we can see that his eyes jump fast horizontally, which is then quantitatively measured here. We see that he has a fast peak velocity when the eyes move horizontally. But when he should move the eyes up or down, his eye movements are very slow. So when they go down, it's very slow. And when they go up, the eyes only move slowly. And we can see that he uses blinking as a trick to circumvent this problem. And the third thing we can see in the same patient is when there is light shining into the right eye, the pupil does not react. When we shine light into the left eye, the pupil reacts very nicely. So what do? We neuro-ophthalmologists, with this kind of information, we maybe, if we don't know by heart, take an anatomy book, and we know there is a region in the brain, this one here, called RIMLF. That's the region in the brain that programs rapid vertical eye movements. So, and this patient has a problem with vertical eye movement. So we know he has a lesion at this point. He has a deviation of the eyes. That's called a skew deviation. That's a problem of the region in the brain that integrates vestibular information of your balance system and transmit it to the eyes. And if this region, it's called the in-C, is broken, there is a little strabismus, a deviation of the eyes. And in between these regions is also the pupillary center where the pupil movements are guided. So in fact, we can just look at these traces and we know this patient has a dorsal midbrain syndrome. So that's the kind of analysis NEOS does. It looks at eye movements, pupil movements, and tries to figure out where in the brain something is wrong. And then you may wonder, yeah, well, is this valid, this kind of examination? And luckily, there is a long scientific tradition of measuring with eye trackers, eye movements. There is literature. Yesterday I counted 12,000 publications on eye tracking that can be used for neurological diagnosis. So there is a huge knowledge base already available. The thing that's missing is a tool that can be clinically used. We also have our own data. I quickly try to show this. That is a very classical exam you see in every doctor's movie. You shine light into the left eye, shine light into the right eye, and try to figure out whether or not the pupil reacts symmetrically. When we measure this with the pupil size over time, when there is light in the right eye and light into the left eye, we can compare how big is the amplitude of this pupillary reaction. That is very important information. Whenever there is an asymmetry of the pupillary reaction, we know that the optic nerve is damaged. If we go back to the example of the multiple sclerosis patients, that's one of the very common first signs is that they get optic neuritis, and the hallmark and the most important clinical sign is that the pupil doesn't react well. We compared the automatic eye tracker to sub-specialists, and we found that the eye tracker does equally good in terms of accuracy and sensitivity as does a clinical sub-specialist. So in fact, it does probably much better than the average doctor. So we can learn from this that the automated RAPD measure, that's one of the 8 measures this device does, is not worse than a neuro-ophthalmologist, and probably much better than a regular ophthalmologist. I still have time? Oh, I can't hear you. You need to nod or shake your head.
You have 4 minutes, and then we have...
Okay. So very briefly, so what I showed you here is that this neuro-ophthalmic exam can be done in an apparative manner. Then we wondered, yeah, well, there is a lot of other devices that examine the eye called optical coherence tomography, autorefractometers, and many others. We wondered, can we combine all these technologies to make a comprehensive eye exam? The goal of this is to make a kind of an industrial examination of the eye, because medicine today is always very personal. Whenever you have a problem, you go and see a doctor, and he makes an very individual examination on you. If we do an automatic examination, we can like use an industrial approach to look at patients. There is such a practice. It's called Ebovis. It's in Zurich, and patients go there. They're not being seen by a doctor, but they're being seen by a lot of apparatuses. As doctors, we then can hit the button and we have an overview of all the findings in a particular patient, and that allows us to make a diagnosis and to formulate an impression and plan. So in terms of doctor's time, there is a massive efficiency gain in an approach like this. And that's like an experiment on how maybe eye care will develop in the future in a way that allows an efficiency gain. And an efficiency gain, we believe, is super important in medicine in the future because health costs are ever expanding. And it's never getting cheaper for very good reasons. And the only way of saving money and still providing good healthcare is by becoming more efficient. That's our proposition of how this could be done. This company, by the way, is very small. It's on the market. It has a product that works already. We look for a CEO because it's 3 doctors that run this small startups, and we need some professional business people on board sometime. So if someone is listening, please call me. Thank you very much.
Well, thank you, Matthias. It's really interesting. It seems that there's a lot going on in terms of ophthalmology associated to neurodegeneration, and certainly it's about biomarker in the eye, but also biomarker in that variable motor biomarker of the optic nerve. So so for now, your product is detecting deficiency in stroke, and at least at the origin where the stroke happened. Can you really pinpoint, depending on the deficiency, the location of the stroke? Is it so precise?
Yes, it is. And the reason why we can is because that's my business anyways, and has been for the last 20 years, to look at these examinations and to find out where has a stroke happened or an inflammation happened. You mentioned biomarkers. So our device is very, very conservative. It just does what skilled neuro-ophthalmologists do anyways. So it's relatively easy to do an interpretation. But of course, there are also changes at the level of the eye movements, and particularly pupil movements for dementia patients. I'm not sure whether my predecessor here has included some pupil markers in his approach, but there are many things that are very different in neurodegenerative diseases, and basically in any disease that affects the brain. But the predictive value often is poor or has not been well demonstrated. So it's not that we can have a look at the eye movements and we know for sure that this patient has dementia. We are not there yet. But these studies are on their way, and in some diseases, probably we will be able to make the diagnosis at the level of the eyes. And in others, like Alzheimer's dementia, I'm a bit skeptical whether it is us who make the diagnosis.
Well, the disease, I mean, the pathophysiology is very diffused in terms of the amyloid deposition and maybe the visual system. I mean, at least in the motor segment, probably there is much more to do. It's easier when you have focal injury, clearly, or Parkinson's disease.
But just, I mean, just as an example, Alzheimer's, because we've started with this. There is one region, the motor nucleus of the pupil, and when you look under the microscope, that seems to be one such place that where damages happen earlier than others, and this one is responsible for the briskness of the pupil movements. So maybe we'll find something there at one point.
Yeah. Okay, fantastic. I don't know if there is any other question. Yeah, Manfred, 2 minutes.
Yeah, quick question. Great talk. Thanks a lot. Has at Lausanne, the Alzheimer conference that takes part every year for 10 years now, there's a distinct focus on diagnostics as well. And this year and also last year, there were several companies from the US who were also focusing on eye diagnostic, but more on the retina. Is your system as well including the retina, or is it more the whole functionality?
Mm-hmm. Well, there is a long tradition. One example you mentioned there, the eye is a window into the brain. You hear that all over the place. And
absolutely.
When people talk about that, they usually mean the retina. But just so to make it clear, I have never, ever heard or seen a patient that has had a diagnosis of any neurodegenerative disease at the level of the retina. So it's science fiction still. And so is it for the eyes. So no, we are really focusing on eye movements and pupil movements. And we try to be very conservative. We try to, we do predict the diseases where we know that it works. And I would be very, very careful to make big claims on Alzheimer's. So I don't want that you understand we're diagnosing Alzheimer's at the level of the eyes. Really, that's not what we do. We find neuroophthalmic diseases, the diseases we know that affect the eye, and maybe sometime in the future we can contribute to, but possibly it will be a mixture of retina, eye movements, and speech, and hand movements, and gait. There are many things where you can recognize, or many areas where you can try to find such a disease.
And second question regarding, apparently you created a company and you want to sell what you have created. How do the costs compare to your 45 minutes of analysis of the setting up the diagnosis? How much is the machine then compared to the time you spend as a doctor?
That depends, of course, on the market, but there is, so we are licensed in Switzerland, England, and we just now start the US, and for the rest of the world, we'll have to wait a little. In Switzerland, I know best, there it's very easy to make to earn money with this device, because the time you save and what you can charge the health insurance is very, very favorable in Switzerland. But that's a bit different in different areas.
Okay.
And I'm not a good person to ask this question. There are business people in this company that know much better.